I'm Sam Gidding, and we're presenting for the International Atherosclerosis Society and the Oman Society for Lipids and Atherosclerosis.
And our talk is entitled Building Evidence for the Next Treatment Paradigm, Curing Atherosclerosis.
We gave this presentation at the 6th IAS-OSLA Course of Lipid Metabolism and Cardiovascular Risk. Our pictures, Jennifer and I are presenting in Muscat. In our middle picture is our host, Khalid Al-Rasadi, and this is at the Royal Oman Opera House. And then we were fortunate to take a day trip out to the Omani desert to enjoy the beautiful desert and scenery of Oman.
So here are our disclosures. So the question is, why cure atherosclerosis? Can it be done?
Now is the time.
So first of all, why cure atherosclerosis? And why aren't we just talking about just preventing heart attacks and strokes? And the reason we're interested in curing atherosclerosis, that's really the disease that we're concerned about. And cardiovascular disease remains the leading cause of death and morbidity. In fact, in 2015, almost half the US population had cardiovascular disease. And if we eliminated major cardiovascular events and death, we could increase life expectancy by 7 years. In the US, we also, cardiovascular disease is the #1 cause of health expenditures, and that's expected to double by 2035 as the population ages. So just think what we could do with all that money if we had it available for other purposes. And finally, I think the most exciting thing is if we can cure atherosclerosis within a generation, we could eliminate cardiovascular disease, morbidity and mortality, and save over $1 trillion a year. So it's a very exciting time, and what we'd like to do now is share the evidence behind that. And I think when we gave this talk in Oman, we really wanted to point out the high global cardiovascular disease prevalence in countries around the world, and maybe that's many countries are not necessarily perceiving that. You can see the US here in orange. We're kind of in the middle of the pack now. We have spent a lot of money with secondary prevention and trying to improve primary prevention, but you can see in the developing countries, especially in the Middle East, and our country in Oman here is on the tip of the Arabian Peninsula. These are amongst the highest countries in the world in terms of cardiovascular death. And as other countries become more prosperous, they're going to see emerging rates approaching these very high rates every year. So why aren't we just focused on, we all know this is a response of obesity, rising prosperity, obesity rates, diabetes. So why aren't we just focused on lifestyle? And I think we've kind of had an experience here in the developed countries that lifestyle is a very frustrating endeavor to try to get people to make and maintain healthy lifestyle changes. But we also know that even if we were able to institute lifestyle changes, we know that those who are at high genetic cardiovascular risk have the highest predisposition. And improving their lifestyle would only cut their risk in half. So humans are predisposed to getting atherosclerosis, and we really need to go more primordially beyond lifestyle and consider drug therapy in these people. Now, the other bit of evidence from epidemiology here is we're actually in the United States and Europe, for example, we're doing a really good job treating older people over 65 with statins, and cardiovascular event rates you can see on the right are actually have fallen quite a bit. But you can see there's almost the same number of cardiovascular events, MI, stroke, and death in those under 65 now, simply because they are not being treated with a long-term lifetime exposure to adverse cardiometabolic milieu. So what we're proposing is really a better paradigm that we're doing now, which is we're down here typically with our prevention efforts. This is a cross-section of the artery through the age, and you can see when people are born, their arteries are pristine, clean vessels, but starting at age 2, fatty streaks start to accumulate. And just as people age, especially, you know, with this bad lifestyle diet, they start to have accumulation of plaque. The plaque grows, it advances, it becomes fibrotic, calcified. And this is where we're devoting almost all of our prevention efforts. In people who have established plaque, it's never going to go away. We can never reverse it. We can stabilize it so people don't have acute plaque ruptures, STEMIs, occlusive plaque, thrombi, but instead, you know, they still have underlying disease, which is stable, but they still have plaque erosions, non-STEMI events. So it really behooves us to really start earlier in the disease process when the plaque is more kind of soft, buttery plaque that's more amenable to regression through lipid lowering, and really try to turn back the clock of the artery to a younger, healthier state. So I would make it the way we do prevention now akin to how, you know, if we were to treat hypertension the same way, we would wait till somebody had end-stage renal disease, and then we'd lower their blood pressure. And that's kind of where we're at now, with waiting till somebody has an event and then doing prevention. And we would like to start treating cholesterol earlier in life, just like we do for hypertension. So the other thing we've learned over the last many decades of research, both epidemiologic as well as basic science research, is that it's the ApoB containing lipoproteins that are the fundamental causal factor in the development of atherosclerosis and its progression. And if we reduce ApoB lipoprotein levels, that means we can have a huge impact on atherosclerosis. Now, ApoB lipoproteins, it sounds kind of confusing. What does that mean? It means LDL cholesterol, VLDL cholesterol, non-HDL cholesterol, all these atherogenic lipoproteins that circulate in the blood. LDL is about 60 to 70%. Each one has an ApoB on it. So all of these are bad, and all of them promote atherosclerosis. And the thing we know is that if you start lowering LDL cholesterol, i.e. ApoB lipoproteins earlier in life, this is actually existing clinical trial data from the cholesterol treatment trialists. You can see that those who are the lowest risk, so less than 5%, less than 10%, 5-year major vascular risk, or 10-year ASCVD, atherosclerotic cardiovascular event risk, they have twice the relative risk reduction as the higher risk people. And that's, again, an illustration of how if we start LDL lowering, ApoB lowering earlier at younger ages, we have a much greater impact on that plaque in terms of regression and stabilization, instead of waiting until people are older with more calcified fibrotic plaque, less amenable to regression. And I think we already, and Dr. Gidding is going to talk about this some more, but we already have evidence, again, that this works starting earlier in life. This is recent data from the Dutch experience, where they've looked at parents with FH, and then now they've started treating the children with FH with statins earlier in life. They've almost completely eliminated the excess risk of that high cholesterol due to genetic causes. So earlier is better. Not lower is better, but earlier is better. We also have other evidence of this from the genetic data, and this is what got us all excited about the PCSK9 inhibitor drug, and this comes from genetic data where they looked at people who had PCSK9 loss of function mutations, and they were heterozygous, so they just had one loss of function mutation. Mean LDL levels of about 100 through their lifespan. They had 88% lower risk of cardiovascular disease through middle age. So a profound importance of LDL cholesterol, i.e. ApoB lipoproteins, keeping those levels low through life.
Now, from these genetic studies, there's been a technique called Mendelian randomization, which essentially mimics a clinical trial. The idea is that your genetic assignment is similar to just randomization in a trial. And this has been done for a large number of LDL cholesterol lowering genes. And essentially what we know is that genetic variation largely determines LDL cholesterol. There's low frequency large effect genes like the FH genes are actually genes that are associated with very low cholesterol. There's high frequency small effect genes which modify your cholesterol a little bit, ApoE being a typical example. There are rare individuals who actually have genes that raise your cholesterol a lot and lower it a lot. They turn out to have normal cholesterol. These Mendelian randomization studies provide the rationale for the benefit of lifelong low LDL cholesterol and the harm of high lifelong LDL. And consistently across all these studies, across all these different genes, about a 50% risk reduction is seen for every millimole per liter or 40 milligrams per deciliter of LDL cholesterol reduction. And this is very consistent with the clinical trial data suggesting there's a greater effect with longer LDL lowering interventions. So short-term trials, the meta-analyses show about a 25% risk reduction. But if you carry the data out longer, you begin to see these more dramatic risk reductions with sustained LDL lowering. On the next slide, we can see a Mendelian randomization analysis for the PCSK9 gene that Jennifer was talking about. And here, what you can look at in this analysis is the proportional risk reduction related to the impact of the specific PCSK9 gene on the lowering of LDL cholesterol. And you can see a very linear relationship of all these different genes related to LDL and PCSK9, akin to the 50% reduction with about a 40 milligram per deciliter reduction of LDL cholesterol.
So taken together, we think all of this evidence suggests that it's really time to explore a new paradigm of curing atherosclerosis, or resetting the vascular aging clock through intermittent therapy. And so this figure just kind of shows you what happens in those familial hypercholesterolemia patients with very high LDL levels. They start to reach the time horizon for cardiovascular events and death really as early as age 20 in some cases. We try to slow that down by starting LDL lowering early. If you wait till adulthood, you can maybe delay that to some extent into the 60s and would make somebody more average in that respect. The next group are those who are just the average person who's got an average LDL level. And what we do, we're waiting really late in the disease, and we're only slightly delaying the onset of disease by 10 to 20 years. And what we would really like to explore, and we think the data suggests, is why not take these people, or really even the FH people, if you could intensively lower LDL earlier in life, cause extensive regression of existing plaque, heal the artery in essence, you can reset that time course, and it starts to look then more like somebody who has genetically low cholesterol their whole lives, like those PCSK9 loss of function mutations. And it may be that those, you would monitor those people, and those who are showing evidence of progression, you would retreat them sometime, within a decade or two, because atherosclerosis is a disease of decades. And we could really eliminate all of these events and really delay the onset of atherosclerosis till late in life, or completely eliminate it. And this therapy is maybe a way to think about this is how we treat cancer, another malignant disease. We do induction therapy to get a handle, shrink the tumor, and then we do maintenance therapy to keep the tumor shrunken. So again, I think changing how we think about atherosclerosis as a disease that can be treated and actually cured, I think is very exciting. Now, a lot of times you'll hear talks by famous people from Harvard about inflammation, and that's really important. But I think the data is really points to the fundamental, absolute requirement to have high LDL, non-HDL, ApoB lipoprotein levels. They are necessary and sufficient to cause atherosclerosis, and that's why we're really focused in on that as our target of therapy. And on the left, you can see just in average population-based studies, people don't get atherosclerosis. In this case, it's subclinical atherosclerosis or even CVD events. They just tend not to get atherosclerosis if the lifetime LDL remains less than 100, or in this case, non-HDL remains less than about 120 or 130. We also have cases where just the presence of very high LDL levels causes atherosclerosis in children. That's homozygous FH. And in that case, obviously they're young, they don't have any other risk factors, but they have 100% ASCVD risk. And I think, in terms of what about these other risk factors, certainly inflammation is important for accelerating atherosclerosis, but it is not sufficient. And this is, I think, real interesting data from the Tsimane tribe. They're a tribe in the Amazon that lives a hunter-gatherer lifestyle, eat a lot of fish and plants, very low cholesterol levels, very, very high CRP levels because they have a high parasite load. And so high CRP levels, they have low LDLs, high CRP, they have no atherosclerosis. And so I think really understanding how important it is to have LDL present. And this is just a figure from one of our publications that kind of outlines all the evidence supporting the atherosclerosis. And this is in the Journal of the American Heart Association. And you can see here that all these ApoB lipoproteins, LDL, VLDL, IDL remnants are all circulating in the blood. And what happens normally is the LDL kind of normally circulates into the subendothelium. Here's the endothelial cells, here's the blood. And if it's small and it's not, there's nothing sticky to make it sticky, it actually circulates back out. But what happens with adverse cardiometabolic milieu, diabetes, insulin resistance, inflammation and stuff, all that LDL gets sticky and it starts to stick in the subendothelium. VLDL, which normally the levels circulating are not that high unless people have insulin resistance and diabetes and obesity, then the levels are higher. It turns out VLDLs are a little bigger and they're really sticky. And as those particles, ApoB lipoproteins accumulate, they get taken up by macrophages. That's the foam cell. And it's the accumulation of foam cells that causes the fatty streak. And it also is very inflammatory and brings in inflammatory and immune cells. And so when you have all these inflammatory mediators, you have the growth of the plaque, dying cells, apoptotic cells, calcification, weakening of the thin fibrous cap, plaque rupture, all these things happening. But what happens when you get rid of all these circulating ApoB lipoproteins, it lets the body's natural mechanism for clearing these toxic lipoproteins kick into gear because you're no longer saturating it. And so normally you have healthy macrophages that come in and start to clear these tangles and particles, reduces the inflammatory mediators, start to have things that stimulate effective, what we call efferocytosis, or eating up all these toxic byproducts and metabolites and dead cells. You start to shrink the plaque. The cholesterol content actually goes down and the fibrous cap thickens. So this is this both shrinks the size of the plaque, but it also stabilizes the plaque. So this is really the intent of getting very low LDL levels so that the body can heal itself. And it turns out that doesn't happen if you have all these other risk factors like hypertension and smoking and diabetes. All these are simply gasoline on the fire of atherosclerosis promoted by those ApoB lipoproteins. So back to the question, why cure atherosclerosis? We think it can be done through short-term intensive therapy to regress the artery, return it to normal, some intriguing data that you can normalize vascular function. The other thing nice about this is you can avoid lifetime therapy. I mean, if you only have to intermittently treat people, that's very helpful too. It's not just a matter of cost, but the pill burden, but also safety in terms of, avoiding a lifetime of therapy. It's also a way that if everybody's treated, avoiding disparities, which we see a lot of here in the US, and there's some interesting data it could reduce hypertension. So let me just show you, I think, some really very exciting data coming from animal studies that really support the hypothesis. This is just one example. There are many others from other laboratories. So if you give animals don't normally get atherosclerosis, you have to tweak them a little bit. And so in these animals, if you give them atherosclerosis with a high-fat chow diet, they get atherosclerotic lesions. And then you can take the chow away, you can give them some drugs, get very, very low cholesterol levels. You can see that there are different stages of atherosclerotic plaque buildup, just like there are in humans. In the later, more advanced stages, you can get remarkable regression, but you don't get it to totally go away. But if you treat the earliest lesions, you can completely regress atherosclerosis, and you can normalize vascular functioning. And so this is very important in terms of thinking about treating earlier where you'll have the most effect on plaque. And of course, we do have human data that we can regress plaque from the IVAS trials of the statins and PCSK9 inhibitors. And indeed, the more you lower LDL below 100, the greater the regression in plaque. Now, it doesn't totally go away, but you can have a big regression of plaque. And this is for both IVAS, but also if you start to look at additional cardiovascular risk reduction, certainly adding PCSK9 inhibitors to statins, you can get progressively more event reduction. Again, all evidence supporting this hypothesis. And then finally, the last piece of the puzzle, which I think is very provocative and potentially quite profound, is that it could be that when we give intensive LDL lowering, start to heal the artery, return vascular function to normal, that actually prevents hypertension. We know from epidemiologic studies that vascular stiffness predates the rise in blood pressure by decades. So if the vascular stiffness is causing from plaque accumulation, we get rid of it, make the vascular normal, we could delay the onset of hypertension potentially for decades, which would have profound impact not just on cardiovascular events, but lots of other causes of death in the world. So we do have some data from giving statins to younger people and even to some extent less diseased older people that statins do lower blood pressure. So we already have clinical trial evidence that this is potentially a real phenomenon. And then finally, the last bit of data are the legacy effects we've observed in the clinical trials. And we know that if we stop statins, the curves remain separated. Those who were on statins during the trial have a lower risk the rest of their lives. And so what we've done is simply turn back the clock on those people by starting to heal their artery while they were on the statin. So now, Sam, I'm going to turn it over to you, and you can talk some more about the disease in kids, because I think that's really important as well.
Thank you, Jennifer. What I would like to do now is present data from the pathologic determinants of atherosclerosis in youth, or PDAY study, which has given us most of our knowledge about the early development of atherosclerosis. In PDAY, at 15 sites around the country, investigators looked at adolescents and young adults aged 15 to 34 years who died prematurely, and then did autopsies on their coronary arteries and descending aortas, and then measured risk factors post-mortem to assess the atherosclerosis. Is the coronary artery of a 19-year-old white male, and you can see that this individual has the early development of fatty streaks and maybe some very early raised lesions. By age 28, you can see the dramatic progression of atherosclerosis just over the course of a decade. This is an MRI from a patient of mine who had familial hypercholesterolemia. And if you look on this MRI of the descending aorta of this 14-year-old, you can see asymmetric wall thickening in the descending aorta, which reflects very early onset of atherosclerosis in a 14-year-old with familial hypercholesterolemia. Now we can compare from the PDAY study a different type of map. These are called density maps, and they're for 4 major risk factors: non-HDL cholesterol, HDL cholesterol, hypertension, and obesity. On the left are people 15 to 24, and on the right, 25 to 34. And top is desirable, and bottom is undesirable risk status. And you can see that within every age group, moving from desirable to undesirable increases the amount of atherosclerosis. And with each decade that you pass by, the intensity of atherosclerosis increases dramatically. This then leads us to look at all these risk factors in individuals. And what we see here is an extremely important graph in terms of our hypothesis. This looks at people in PDAY over 5-year intervals from 15 to 19 to 30 to 34 and stratifies them by number of risk factors from 0 to 4+. And what you can see is that between the ages of 15 and 20, that there's actually very little separation in advanced atherosclerosis. In fact, the only risk factor which is associated with advanced plaque in this age group, in this population-based study, is diabetes. However, based on the number of risk factors, you can see that atherosclerosis accelerates at different rates. If you have no risk factors, essentially you develop very little atherosclerosis through age 34. Once you have one risk factor or a little over one risk factor, which is typical in the population, you see a slow and steady advance. But if you have multiple risk factors, the amount of atherosclerosis accelerates. This led us to develop the PDAY risk score. And the PDAY risk score then provides a weight for atherosclerosis development based on your risk. And though these numbers are small, essentially what it allows you is to assign a point value to risk factors measured early in life to determine future atherosclerosis or predict the amount of atherosclerosis an individual might have. Now the score works. Here you can see the prevalence of raised lesions in the right coronary artery by risk score. If your risk score is below 5, your vessels are clean. And if you get up to 16+, there's a tremendous amount of atherosclerosis present. Now, another key element of the original study was to look at the likelihood of having atherosclerosis by score. So this is graphs for both the abdominal aorta and coronary arteries from our original publication. And what you can see as you move from left to right is as the risk score goes up, the probability of having advanced atherosclerosis goes up dramatically. However, I think it's important to remember that atherosclerosis does not progress at the same rate in any individual. So though having a high score makes atherosclerosis, advanced atherosclerosis likely, in fact, only about 50 or 60% of people with an advanced score will have advanced atherosclerosis. This will become important when we discuss our clinical trial designs later in the talk. Now we took these risk scores and then applied them to a living population for validation. And the population we chose was the CARDIA study because in CARDIA at baseline, the population was age 18 to 30 years, whites and blacks. And 15 years later, at age 33 to 45, the people in the CARDIA study had CT scans done. And what we look at here is the baseline year 0 PDAY risk score on the x-axis. And on the y-axis is the odds ratio for coronary calcium development. Now, the tertiles are tertiles of change in risk. So at the far left are people with the lowest PDAY risk score at baseline, and you can see that they had very little coronary calcium 15 years later. The group who increased their risk score had more than the other groups. As you move up to intermediate and highest, you can see a clear stair-step relationship between baseline risk at age 18 to 30 and future atherosclerosis, with about a 9-fold difference between those people at low risk and baseline and low change versus high risk and high change. So again, this age group is where atherosclerosis is kicking off. Next. The next slide takes these results a little further. We repeated this study at year 25 in cardia. This slide shows risk assessed at all the different cardia exam years up until year 25 when coronary calcium was remeasured. And as you go up the exam years, you can see that the likelihood of having CAC by the PDAY score, the likelihood was actually highest at baseline, 1.29 per point or 1 year of aging in the score. And it drops down, and the worst was actually at year 25, where the odds ratio is only 1.12. Also, the C statistics stay high for those first 3 exam years and start to fall off after that. The way we interpret this data is that chronic exposure matters in terms of developing atherosclerosis. Those people who had risk at a very early age and sustained that risk were much more likely to have CAC later in life. We actually believe that the reason that CAC is important in risk reclassification isn't because there's something magical about CAC, but it's really a measure of this chronic risk exposure over a lifetime versus risk measured at the time of the CAC evaluation. Now, Jennifer has taken this data and looked at the likelihood of having a probability of an atheroma across a different age range. So you can see on the left the probability score, and on the right in the table, examples of cohorts that have 40 to 60% or greater than 60% probability of an atheroma. So men with a PDAY score of 18 to 23 would be age 36 to 45, or age 30 to 35 plus obesity, or age 20 to 29 with multiple risk. For women, the likelihood would be a higher score and beginning in early middle age, 41 to 45 with overweight, or a little bit younger with other risk factors. For men to have a very high score with a 60% probability, again, you're talking about ages 20 to 29 with a non-HDL cholesterol of 160 to 189 and hypertension. So a multiple risk youth, even at age 20 to 29, or with slightly lower risk in the 4th decade of life, has a 60% probability of having an atheroma. Now, familial hypercholesterolemia, as we've discussed before, provides an excellent model for understanding the impact of ApoB lipoproteins on atherosclerosis. This is data from Bert Wiegmann, and back in the 90s, he started a pravastatin trial in children to see the impact of pravastatin on LDL cholesterol and carotid IMT in children. But he also at the same time started an observational cohort of the siblings of those children with FH. So this compares the carotid IMT thickness of children with FH to their siblings, and what you can see is that at about age 10, that's when the carotid IMT difference is perceptible across affected and unaffected siblings. This is a CT scan of a 14-year-old in my practice showing atherosclerosis in the left main coronary artery of this child who had a total cholesterol of over 400. We published in the late 90s the fact that 28% of children with familial hypercholesterolemia have measurable coronary calcium. The idea of chronic exposure being important and lifelong exposure to familial hypercholesterolemia was highlighted by Kara et al. When they looked at 11 large cohort studies and looked at FH status within these clinical trials and observational studies. And what they showed is that the presence of an FH gene tripled risk for coronary heart disease at any level of cholesterol. again supporting the chronic exposure hypothesis. It's also important to recognize the importance of LDL cholesterol as a risk factor in this setting, because as the LDL cholesterol goes up, the risk for a heart attack dramatically increases as well. So it's a combination of the elevation of LDL cholesterol plus the chronic exposure that produces the atherosclerosis. Now, as Jennifer mentioned, this New England Journal study is a 20-year follow-up of those children who were in the clinical trial that I mentioned before. So Dr. Wiegman and his colleagues followed these people who were in the original pravastatin trial for well over 20 years. And you can see that by age 40, only one child who was treated with pravastatin beginning in adolescence had a cardiovascular event, whereas the event rate in the parents was close to 30%. So what's also interesting is that these event rates translated into several key additional findings. First, the achieved LDL in this group of children was much higher than typical goals later in life. 4.16 millimoles was the achieved, which is about 160 milligrams per deciliter. This is compared to about 120 milligrams per deciliter in their siblings. Amazingly, there was a large mortality benefit, much larger than seen on a percentage basis in the adult trials. There were no deaths among the FH patients, and 11 of the 156 parents of these patients who data was available on had passed away. There were no, I repeat, no major adverse events or side effects during over 2 decades of follow-up on statin treatment. And in terms of diabetes, only 1 in 184 of the patients where data was available had diabetes versus 2 of the 77 siblings. Carotid IMT was remeasured at, in this study. And this is, again, looking at these children versus their siblings. And you can see that at baseline that the FH patients had a higher IMT than their siblings. And the rate of progression of IMT was unchanged between the two groups. In fact, the FH patients got closer to their unaffected siblings. If you actually do a sub-analysis on those children who got to goal, you can see that their carotid IMT was actually thinner than their unaffected siblings. So we need clinical trials to determine if atherosclerosis can be cured. Why? Cardiovascular disease remains the leading cause of death and major cause of morbidity in the US and globally. As we mentioned, 42% of the US population has some form of cardiovascular disease. And if we eliminate it, it would dramatically increase life expectancy. We want to get rid of all those excess healthcare expenditures. We're now going to transition to a point where we discuss certain types of trial designs that might be helpful in proving the hypothesis. So there is a trial ongoing for the DO-IT study. We don't have a slide for this, but essentially this is a trial of multiple risk late adolescents who are going to get randomized to statin therapy or no statin therapy with pulse wave velocity as a clinical endpoint. So that trial is currently underway and is sponsored by NIH. A second type of trial is to determine the importance of imaging. Currently, CAC is the only imaging modality that seems to help in risk classification. However, most of these studies are looking at much later phases of the disease. We think that atherosclerosis imaging is important for risk stratification earlier, and this is an example of a trial design that could get at that. So first, for example, we've taken FH patients who get a subclinical atheroma measure. You divide those patients into those who test positive and test negative, and then you continue with your randomized intervention at lower and higher intensity. And then you can look at progression of atherosclerosis in all 4 groups. If you believe that there's some vascular protective factor that exists in those who test negative, then the rate of progression in the lower intensity treatment group should still be very slow in comparison to rates of progression in the other groups. So you can look at this, and if stratification by amount of atherosclerosis on imaging is important. This will let you know that early, by incorporating this risk stratification in the design, will let you know the importance of imaging in predicting later atherosclerosis outcomes. So again, this is our basic figure and our idea that if you start early in life, that you can keep the amount of atherosclerosis very low and keep vessels in a healthy state.
So Sam's talked about drug trials, and again, I want to reiterate, we have to do drug trials. Lifestyle is not sufficient. Humans are genetically predisposed in the first place to atherosclerosis, and lifestyle only, it cuts the risk in half, but it does not eliminate the risk. And so we've proposed a trial in adults as well called Curing Early Atherosclerosis, or Cure-Athero. And hopefully we're excited that someday this might be funded, but this is sort of the design we think is necessary, at least to be done as a proof of concept, as the first step in identifying those who are most likely to benefit from this intensive therapy early in life as the starting place. So the Cure-Athero study population, healthy men and women aged 25 to 55, a little older so we can get some women in there because their risk is delayed by about a decade. Overweight or obese with increased risk factor levels, as Sam showed you, those are the people who are extremely high risk and have evidence of premature atherosclerosis. People who have a significant burden of uncalcified plaque, because once you have calcified plaque, again, you're farther along the spectrum of disease, less likely to be regressed and have healing of the artery. And then we would use the PDAY score that would result in about a 40% probability of having atheroma present. We calculated the power. We would have to randomize 130 subjects, although we would love to get more money and do subgroup analyses by gender, for example, and do predictive analyses with larger studies. The treatment would be for 3 years, randomized to usual care or control, i.e. control, because these people are not currently candidates for lipid-lowering therapy at all. And the intensive intervention arm would be to try to get the LDLs down to 20 to 40 milligrams per deciliter, about 0.5 to 1 millimoles. And that, in most people, would require a moderate or high intensity statin plus a PCSK9 inhibitor, and some might also need ezetimibe. And so the main objectives would be to characterize the response to intensive lipid-lowering therapy over a period of 3 years. And that would let us design not just future imaging trials, but outcomes trials, and really to start at the top of the pyramid of risk to determine if we can have this major impact on almost complete atherosclerosis regression. And we also would, of course, develop risk prediction algorithms and all those other things that people could use in their clinical practice. So it's a pilot. Cure-Athero is a pilot. Really, it's going to identify a sweet spot for atheroma regression. You don't want to start too early, but on the other hand, you don't want to wait too late when there's a big burden of atherosclerosis already present. Obviously, genetics, other imaging, certainly PET scanning would be of interest to look at what's happening to earlier stages of plaque, other than the actual visible low attenuation plaque volume. And really, it will address a really important evidence gap, even in the observational arm. What is the rate of atherosclerosis progression in these young adults? We just really don't have a good handle on that. What we're working on now is to work on more efficient screening algorithms. And I think the concept that you can take away is take the top 25% of people in risk factor levels, and then amongst those, take the top 25% of the genetic risk score. And we have a number of good genetic risk scores now. And that's really going to be the most susceptible people who are going to have evidence of atheroma on imaging. But they're also, we know from other studies, these are also people who are the most responsive to lipid-lowering therapy. And so we're just working on fine-tuning that right now. So we've had actually a number of genetic studies. This is just an example from the trials. And in red, it certainly shows that those at the highest genetic risk have the highest risk in the trial. And they also have the greatest response to therapy. So again, the first trial, we're going to have to do, we can do imaging trials, but ultimately we'll need to have cardiovascular outcomes trials. But once we find this very susceptible group, we anticipate we'd have an 80%, up to 80% reduction in cardiovascular events. These people still have events in this high-risk group. We could do a trial with less than 10,000 people for 5 years with excellent power. So we think this is, we need a little bit more data, but this is really the next step in clinical trials. Now, I just want to talk a little bit more about shorter-term imaging and outcomes trials. And the reason we need these trials is again, we have to find the sweet spot. We have to find those who are most responsive to therapy. We have to build our case really and set the stage for therapies in the near term. Of course, we have inclisiran, which is going to be a twice-a-year injection. But the next step is really going to be genetic engineering, and this is already happening. I kind of thought I was going to be too old for this, but it's happening. It's one of these exponential functions of the rapidity of development. So people are already developing gene therapies. In fact, people have done germline editing already, much to people's chagrin. So this is around the corner. Obviously, we need to know, is it effective, but also, is it safe? And our colleague, Sek Kathrayson, already at the Brigham, done really the forefront of the genetic research, finding key genetic variants that increase cardiovascular risk, now as the CEO of Verve Therapeutics. And they are certainly doing animal studies now, but they are rapidly moving into human trials to try to do some somatic cell editing, i.e. the liver, where you could start to knock out some of these genes like PCSK9 and try to recapitulate that PCSK9 loss of function mutation. So this is coming, but I don't think we want to be knocking out genes without finding out if it actually has the effect that we desired and in whom to start to see if there's efficacy. So the reason we can edit genes, you may or may not have heard of CRISPR. It's basically little genetic scissors that snip out the bad DNA and insert the good DNA. And we've now, I think, probably mastered the technology where we can do that accurately. It's already there are already some approved genetic therapies on the market for very rare diseases. So this is here already. You want to be careful about cutting out DNA and putting it back in the right place. And so the laboratory people are working on these, but now we have CRISPR prime, and that seems to be under control. We don't want to be causing cancer with our therapy by putting the gene in the wrong place. And I think people feel now that we are going to be able to do this accurately. There are, other than the infamous Dr. Who gene edited the Chinese babies, there are kind of under the radar, and I think he's that met widespread disapproval for that. There are other researchers already who are working on gene-edited babies for congenital diseases and things like that. So this is just the beginning, and we want to, by doing some of these trials with like Cure Athero, really set the stage for when these therapies are proven to be safe and effective, that we are ready to hit the ground running, because if you can gene edit something like PCSK9 and keep LDL levels low throughout the lifespan, we truly can eliminate cardiovascular disease in the human population. So it's an exciting time, and it's really been the response of many, many decades of research by thousands and thousands of scientists over the years, and clinical trial and epidemiologic study participants. So we are excited to see what the future holds.
Yes, I think I agree with you completely. We're in a very exciting era, and I'm actually not that sorry that I'm retired, but just sorry enough from an intellectual capacity or stimulation side of things. But I think it's important to people to understand that we really are emphasizing trials, not go out and just throw lipid-lowering drugs at everyone in the population. We actually believe that the lifetime burden of atherosclerosis can be reduced with shorter courses of lifetime therapy that are better timed in the natural history of the condition.
Yeah, and I think that's really important, because I think the other thing people don't understand, we don't want to treat everybody. Not everybody is going to get atherosclerosis. I mean, they may get it eventually, but it might be in their 90s. So we're not advocating treating people for 50 or 60 years. What we'd like to do is do more precision therapy and start treating only those who would have had their events in their 40s or 50s early, and kind of waiting to the right time in somebody's life to start intensive therapy. For some people, that might be for the FH at age 8. For a high-risk obese adult, it might be, age 25, or, somebody who's pretty healthy but with a bad genetic load, maybe waiting until they're 50 or 55. So again, I think well, we have to do trials. We have to show that it works and that it's safe and effective to convince a broad population.
Yeah, as a pediatric cardiologist, one of the things that I find strange in adult conversation is the concept of residual risk. To me, residual risk is the lost opportunity from not treating early. It's that amount of atherosclerosis that can't be regressed and still puts you at risk for a thrombotic or acute event.
Well, I agree, and I every time I get a paper to review, I guess you can tell if I review your paper and I cross out residual risk and I say, quantitate the risk. They remain at extremely high risk. This is unacceptable. Why did we ever let them get to that high of risk? And so I think that's, we really want people to have zero risk. And so I think that's the real game changer here. But we have to do trials and we have to convince people. But I would love to change the conversation from, again, as I mentioned at the beginning, preventing heart attacks and strokes and trying to get LDL to ever lower goals of, 1 millimole or 45, whatever, 30, whatever somebody lipidologist comes up next. Get the whole conversation away from that and talk about earlier is better, and really trying to alter the natural history of the actual disease, which is atherosclerosis.
Yeah, I think that is the core concept. I think for us, atherosclerosis is a disease and events are a consequence. And I think you can see that just looking at risk factors. For example, passive smoke exposure is a risk factor for an event, but probably doesn't lead to a lot of atherosclerosis development. Inflammatory markers are markers of this very late phase of disease. And it seems like the people who benefit from anti-inflammatory interventions are way out there with established atherosclerosis. It's not part of early prevention.
Right. Absolutely. I've been calling all these expensive new drugs that keep coming out, moving expensive deck chairs on the Titanic. I mean, it's too late. I would love to see that amount of money spent on earlier prevention and have such a greater impact. But of course, we need clinical trials to do that, and hopefully the drug industry, will realize that you can make money with not such expensive drugs if they are used by most people on the planet to prevent atherosclerosis. It's just changing the conversation a little bit. So stay tuned, and hopefully we'll move forward in this area.
Yes, we're very happy to present these thoughts to a larger audience.